So for today's hot topic series, and maybe just a little reset. So a couple of years ago, we started this process of formally, regularly scheduled hot topics meetings on specific items of interest that people would be interested in. And we find the best people out there who know what they're talking about to come and talk on this topic. So today's the first Hot Topics series of 2025, and we will have more throughout the year. So take a look at our NADO website, or the calendar there, to find out when the other days will be. If you have suggestions for hot topics, please forward those along. We set these agendas only just a few weeks in advance so that it is truly the hot topics of what people want to hear about. So if you have ideas, please send them along to us. We're always interested in hearing about that. What's on your minds? What do you want to hear from? And if you have suggestions for speakers that you'd like to hear from, also please send those along. So we do have a quick announcement just to let you all know that the pre-registration for our in-person meeting in Austin, Texas in May will be coming up, or the meeting will be coming up in May, and pre-registration is available. Some people have asked, what's the difference between pre-registration and registration? The difference is you don't have to pay for pre-registration yet. So you can reserve your spot, you can go talk to your boss, you can get all of your paperwork done, but know that you have a spot. And that's important because last year we literally ran out of spots. So if you think you want to come, or you're not sure, but you're going to try to get approval, go ahead and pre-register now so that we are aware of you and that we can save you a spot. So we're excited to announce that for you. That information, of course, is available on our website, or the NADO newsletter will be coming out later this afternoon. You can watch it there as well. So we are ready to go ahead and start our meeting, our presentation today. The hot topic for today is harnessing the power of claims data to improve public health. And we're excited to have our friends from CIVHC, the Center for Improving Value in Healthcare in Colorado, with us. We have Clare Leather, Valerie Garrison, and Rachel Jardim. So I'm going to go ahead and turn the time over to our presenters, and they can introduce themselves and tell you a little bit more about themselves and get right into the presentation.
I knew I was going to forget to unmute. Thank you so much, Norm, for the introduction. So I'm Val Garrison. I'm an evaluation analyst at CIVHC. So I'll get us started, and then you'll hear from Clare Leather, our public reporting manager, and Rachel Jardim, our evaluation analyst. In case anybody on the call is not familiar with CIVHC, our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data needed to improve health and healthcare. So we look at healthcare accessibility, healthcare quality, health outcomes, affordability, etc. And we work under a health equity lens. So much of the work that we do really emphasizes understanding differences between populations and really pushing for health equity so that everyone has the opportunity to be healthy. We are a nonprofit organization, which means that we are independent and objective, and we pride ourselves on being service-oriented and providing high-quality data and services. We serve folks whom we've referred to as change agents. So these are individuals, communities, or organizations that are working to advance our mission. And these include the groups that you see at the right here, but it's really has a broad, we run the gamut in terms of types of partners who we work with. And we're always exploring new opportunities and partnerships and learning more about change agents in this space. Specifically related to public health and health policy, we work closely with a wide range of organizations that do have a significant impact on public health, whether that's directly affecting public health or even running programs that have a tangential benefit to public health, even if that's not their main focus. And these may include state and local government. We've done projects with safety net clinics, health clinics, federally qualified health centers, numerous community organizations ranging from food banks and food service organizations all the way to community health workers, etc. So Clare and Rachel are now going to walk you through some projects that we've worked on at Civic as examples of how we have used health claims data specifically in the space of public health. You'll see that for the purpose of this presentation, we kind of group these into three main buckets: surveillance, policy evaluation, and resource allocation. These are three key areas that we've found can significantly benefit from use of health claims data. But you'll also note there's a lot of overlap between those categories. For example, policy evaluation and resource allocation often take into account surveillance data, so on and so forth. So these are not hard and fast rules. It was just a way to kind of organize the projects that we've worked on. And then after we share those examples, we'll go ahead and just have a discussion about the data and projects that you're working on. So Claire, would you like to take us off with surveillance?
Yeah, thank you so much, Val. And thank you all for having us today and participating and joining us. So the first area we're going to discuss, as Val mentioned, is surveillance. So Civic uses data in a wide variety of ways to support this sort of broad topic. So first and foremost, we can use data to allow public health agencies and organizations to act quickly during times of of public health emergencies. Our public dashboards, which is an area that I manage, help organizations and different community members identify emerging challenges and sort of track changes over the long term to sort of see what's happening in the future over sort of a longer time periods. And then our custom reports really enable our partners to understand patterns related to topics and issues that they're specifically looking at. So our custom reports are very, very specific to the needs of our clients and support their specific work. So some of the projects we're going to jump into now. So this project is came out of obviously the public health emergency that happened not too long ago. This came from a need of Colorado Department of Health Care Policy and Financing during the COVID pandemic. I'm sure, as many of you recall, there were limited quantities of vaccine available. So we helped answer a critical question for vaccine distribution, which was identifying populations in the state at risk for serious illness from COVID-19. We produced county level data with key demographic information, looking specifically at the 65 plus population and seeing the population size, and then seeing really the breakdown of what chronic diseases in that population at that county. So we looked at chronic lung disease, heart disease, the immunocompromised, severe obesity, tobacco use, diabetes, and then chronic kidney and liver disease. This level of detail really helped regarding how to sort of inform the vaccine rollout in the state to ensure that those sort of at the highest risk, with the highest comorbidities and needs and healthcare needs, had an opportunity to get vaccinated first because there was limited quantities of vaccine. So this was sort of an urgent request that came up rather quickly. I actually wasn't at Civic at the time when this happened, but I do know that this was an important piece of data that the state used. Our next topic is something actually we just did this past year. This project came from a Colorado state legislator looking to better understand the impact of firearm injuries in the state. There's a lot of information out there about death rates and mortality rates from firearms in our state, but there isn't a ton of information about injuries specifically. So this kind of surveillance data is unique. Again, we don't have records, we don't have death records in the APCD, but we do have these kinds of records that can be broken down into different demographic categories. And really importantly for this work, I'm looking at the injury type category. So seeing like what actually caused this injury. The question was basically what are the volume per person rates, overall costs and trends over time related to firearm injury. We compared injury costs injury costs and volume across sex, age, urban and rural distinctions and payer type. And the key finding that we found was seeing unintentional injuries resulting from firearm discharge really made up a majority of the claims data that we were seeing, and a majority of those came in rural communities, and we were seeing an increase in demographic groups, most notably in the pediatric population. So these findings helped inform the future legislation that this legislator is currently working on. This project had obviously a surveillance element to it, but as Val discussed, this is really a place where overlap, because it is informing sort of policy creation around firearm safety initiatives and programs in the state. And now I'm going to pass the baton off to Rachel.
Yeah, thank you so much, Claire. So another way that we wanted to chat with you all about how Civic informs public health and public health policy is through policy evaluation. And Val and I are on the evaluation and research team at Civic, so we do a whole lot of this. So state and nonprofit partners across the state frequently approach Civic asking if we can help evaluate the impact of a policy on health or healthcare. And claims data are a really great way to do that because we get a snapshot of healthcare utilization across the state, and we also get information on all insurance types. And policy evaluation can help us understand the impact of existing policies, help us highlight the need for new policies, and help inform the development of those new policies as well. So one recent evaluation of a policy that we did at Civic was looking at the impact of Medicaid unwind. So Civic originally published data, which you can see here to the right on your screen, about what happened to Medicaid enrollment levels following the Medicaid unwind in spring of 2023. When folks who had provisionary Medicaid coverage due to the COVID-19 pandemic were disenrolled from coverage kind of en masse. And you can see that there was a really steep decline in Medicaid coverage in the months following this policy. So a safety net clinic approached us this year asking if we could continue work on that evaluation. They came to us and they shared that they have seen a really large increase in their uninsured population and their uninsured rates at their clinics. And they asked what happened to these folks who were disenrolled for Medicaid in spring 2023. So our current project is tracking those people to understand what's happening to them and their insurance coverage. So are they getting re-enrolled in commercial coverage? Are they going back to Medicaid? Are they becoming part of an uninsured population in the state? And our evaluation is really helping this clinic look at their resources and to understand what's happening in the state at large. Another project that I've been working on, which is really exciting, is an evaluation of community health workers. So there was a policy that was passed in 2023. The Colorado State Legislature passed a bill to allow for Medicaid reimbursement of community health worker services starting in 2025. In 2024, they also proposed to have the Center for Medicaid Services, Medicaid and Medicare services start reimbursing for Medicare. And there's a large push at the state level to have commercial payers start reimbursing for these services as well. And so a university partner came to us and they asked if we could look at the impact of having access to community health worker services, specifically for patients with chronic disease. And to help answer this question, we used claims data to develop a couple cohorts of type 2 diabetic patients with and without access to community health workers across the state, looking at the impact of access on healthcare utilization and some health metrics, like you can see to the right, the amount of diabetic medication gaps they're having on an annual basis.
And this ongoing evaluation is going to continue for the next 2 years, but we're really excited to be playing an important role in showing the potential benefit of having community health workers access for patients with chronic disease across the state, and potentially helping to inform future policy development and get reimbursement for these really awesome services. Finally, another way that Civic is really closely involved in public health work is through some of those surveillance activities that help to inform resource allocation. So as Claire already shared, such as the COVID vaccine distribution, a lot of our surveillance activities help folks across the state, partners across the state, decide how to best use the resources that they have. And claims analysis can help us get a better picture of what's happening in the state because we have a really comprehensive data set that allows us to observe trends on the state level, not in real time, but pretty closely. I'm going to pass it off to Claire to talk about a wildfire and ozone project we recently did.
Thanks so much, Rachel. This was actually another recent analysis, and this was another request that came from a Colorado state legislator who sits on the wildfire subcommittee that was looking for data to sort of better understand the healthcare impacts of wildfires in our state. Colorado, unfortunately, is a very wildfire prone state. And we also have really, really high levels of ozone in the state. These two combined can produce some very poor air quality. So the question we wanted to answer in this project was, when are most people impacted by high level of air pollutants? And then underlying that, like, who are these people? Our project used not only claims data, but we also used EPA monitoring site data that reports on pollutant levels in different counties to see when there were spikes in pollutants in the air caused by ozone and wildfire specifically. And then we took that information and paired it with emergency department rates, admission rates for respiratory and cardiovascular disease across all the different counties in the state. And again, we were looking at the differences between those months with and without spikes in air pollutants. Our findings show that there was some seasonal patterns. As we all know, there's some seasonal patterns with healthcare, with these kinds of healthcare diseases. But we found that in months when there was a spike versus months when there wasn't a spike, youth and seniors, children and youth specifically, experienced higher rates of ED admissions for those months. This could be that, you know, the air quality was exacerbating these seasonal trends that we already see in healthcare. You know, often when we're talking about environmental disasters, people are really concerned about the immediate relief needs of what's happening in a community. And how to fight the wildfire and how to take care of the people that are being impacted. But there are wider healthcare implications for everyone who's breathing the air in those communities and not in those communities that require sort of planning and resource allocation. This data set was really well received, and the legislators, again, are using this to sort of think about the budget and how to allocate resources to communities that are experiencing really poor air quality, specifically looking at those populations that are more vulnerable and that might need more health care and that might need more assistance during those times. So we actually think we're going to do a part 2 of this and get even more specific and maybe look at pharmacy fills for certain drugs and looking at even some more specific diagnoses, not as high level as respiratory and cardiovascular, but sort of going a little deeper to see what the results look like. So very exciting. And I'll shift it over to Rachel so she can talk about an RPI project.
Thanks, Claire. Yeah, so this was another project that we completed in the last year, and I was really grateful to be a part of. So the Colorado Department of Public Health and the Environment, CDPHE, approached Civic alongside an American Indian and Alaska Native serving organization and asked us if we could do an analysis. This specific organization operates a mobile clinic that serves American Indian and Alaska Native individuals across Colorado. And this mobile clinic was really special. They have tailored services that are culturally relevant for these communities, but they really wanted to maximize like their outreach across the state. And they came to us because there's actually not great data that currently exists about where individuals that identify as American Indian Alaska Native reside across the state. And the Colorado All-Payer Claims Database was one way they could help answer that question. So what we did is we did a geographic analysis for them. So we looked at eligibility and race ethnicity in the Colorado All-Payer Claims Database. And we mapped out for them where individuals with eligibility in the COAPCD reside in Colorado, and shared with them some information about other demographics, so age bands for these individuals, as well as their insurance types. And this was super useful for them. So they actually took this information and helped to really focus their outreach on the southwestern and northeastern corners of the state. And it also helped them to kind of anticipate what sorts of folks and what kind of insurance types they might be serving when they did their outreach. And so this was a really exciting analysis for us, and we're hoping to continue to partner with some of these organizations across the state to help other folks really maximize the use of their resources. And personally, it was really wonderful project to complete and to contribute to. And I'll hand it back to Claire to talk about our last project.
Thank you, Rachel. Again, getting back into our time machine, going back to COVID-19. This request, again, came from our Department of Healthcare Policy and Financing folks, looking at the estimation of the financial impact of the temporary cessation of all elective and non-essential procedures. This was a fairly common executive order across the country that came from the governors to halt any elective procedures, non-essential procedures during the pandemic public health emergency. But obviously, there were going to be some financial implications to hospitals and the healthcare delivery system on a whole. So we just ran something really basic analysis looking at the cost and utilization data from previous years to estimate what that financial hit would look like. And we found that elective procedures, those non-essential procedures, amounted to about $200 million per month for provider payments, and accounted for about 63% of payments to providers. So understanding this sort of large financial hit helped the state better think through where to allocate pandemic aid during a time when resources were limited. And there were looking especially at the providers serving rural communities, at critical access hospitals, these places that really are already financially in a tricky spot. This data sort of helped illuminate where those holes could be, broadly speaking. And so it was one of those things. I was not here for it, but it was one of those very quick projects that we turned around in order to support the state and their efforts, really figuring out what to do and responding to the pandemic in a thoughtful way to save as many lives as possible, and to keep everybody employed, and take care of the healthcare system that was really under tremendous strain during the pandemic.
Okay, thank you so much, Claire and Rachel, for running through those. So as you can tell, we have a very broad range of projects that we work on. These are only a small handful of the projects that we have going that affect public health and look at public health policy. But we can only fit so much into one presentation. So hopefully it kind of got your gears thinking about your own work and your own needs. And so I want to go ahead and start a discussion. Before we jump into that, I do want to share our contact information. So you can reach us directly using our first initial last name at civic.org. And we can go ahead, Claire or Rachel, if one of you are willing to pop those in the chat, that would be really helpful. You can also connect with us on the socials, or you can join our mailing list at civic.org. And so I just wanted to share these with you before we jump into that discussion, as we know some folks are not able to stay the whole time. But we would love to hear from you, any thoughts or questions that you had going through this presentation. And then we also thought up some questions to kind of get the conversation going. So what we would love to hear is what data your organizations currently lack for informed decision making if you are an organization that needs to make public health decisions. What challenges have you faced when using claims data, if you've tried that in the past to support public health initiatives? Any examples that you have that you could add to the work that we've done, and any additional opportunities that you see for claims data to further support public health initiatives. So I'm just going to leave this slide up while we chat. And yeah, since I've been sharing my screen, I am not able to see the chat. So I'm curious what's in there.
So not all of our participants can see the chat, so that is a good question. But certainly, if people have comments or questions, go ahead and raise your hand or just take yourself off mute and introduce yourself. That would be great. We'll try to, hopefully people not get too excited and everyone speak at once. Usually that's not the problem though. So if anybody has any answers to those questions or questions for our presenters, comments, anything, we'd love to hear from you now. That was a great presentation, but surely there are questions. Anyone? Okay, there we go. Ganza, do you want to go ahead and go first?
I could. So thank you very much for the presentation and the examples. As many folks out there, many on this chat as well, are trying to evaluate the uses of this data for public health. I'm wondering, have you had a chance to look at different types of health outcomes and which ones would be better suited to using claims versus maybe other types of surveillance data? And which ones would be better suited for using maybe claims plus maybe some additional information like lab, pharmacy kind of data? And can you share your experience on that?
Yeah, so one example might be, and I should probably let Rachel answer this one, but for the type 2 diabetes project with the community health workers, their interest was in looking at prescription adherence, healthcare visits, that sort of thing, which tailors itself really well to the use of health claims data. So we can see the frequency of the touch points that those individuals are receiving, and we can get some measures of standard care, such as timing of visits, frequency, et cetera. If we were looking at specifically the acuity of the disease itself and how well controlled the diabetes is, for example, another data set such as the actual A1C values would be a beneficial data element that we don't have access to in the claims data. So we wouldn't actually be able to track, are folks getting healthier aside from seeing, oh, they're needing less medication, they're going to the hospital less often, that sort of thing. So from the utilization perspective, the APCD is great, but a different data source is better for like kind of individual improvement in their overall condition measures.
Yeah, and I can jump in as well. So I have a background as an epidemiologist and for the health department, and I think that there are certain conditions. So, like when we think about what can we really glean from claims data, we have to acknowledge that we receive claims data from payers at like a 3 to 6 month delay. So in terms of actionable insights for public health, it's really thinking more about chronic disease insights. I think a lot of communicable diseases, so like reportable conditions, um, those sorts of immediate act, like if you're going to act on um, an immediate threat, looking towards like EpiTracks or Essence, those databases that collect more timely information are really helpful. But as Val said, for um, conditions that have some delay or that we're trying to look over the longer term, I think claims data are really, really useful. Um, so yeah, we've been doing a lot of chronic disease work and on our team, and also trying to look for patterns in healthcare utilization as Val mentioned. So I think bringing in some of that pharmacy data is often very useful. And of course, any cost related data, so access questions, we get a lot of those on our team as well.
And I just, oh, sorry, can I just jump in real quick just to clarify something? We actually do receive monthly pay data from our payers. It just takes a couple months to actually process the data. So we receive data every month. It just takes 1 or probably 2 months to actually process the data and get it ingested into the APCD for us to use it. So just wanted to make that clarification.
Thanks, Claire. This also has me thinking about another project that I worked on was around investing in infrastructure for primary care, particularly in communities that lack access or have lower resources. And the health equity focus of that project. So I mentioned a lot of our work takes on a health equity lens, and I'm sure nobody on this call is surprised to hear there are some limitations with the health claims data in terms of demographic information and things like that. And when you're thinking about public health specifically, it's a little it's interesting because there are so many social drivers of health that can influence an individual's health status and health outcomes that it can be difficult to account for those when you're using the claims data explicitly. So we know that Z-scores exist, but they're not used that frequently, and it's difficult to rely on those, especially when you're comparing cohorts and things like that. So one of the ways that we've worked around that is using ACS census data. So the Colorado APCD is geocoded to the census tract level. And so one thing we're exploring with some of our projects is finding so the CDC every year produces a social vulnerability index scale. So for all census tracts, there's a calculated index that uses, I believe it's 20 or 20, somewhere between 20 and 25 of the social measures from census data to calculate a social vulnerability score based on an individual's location. So we're not able to say an individual specifically has XYZ risks, but we do know that if you live in a neighborhood in which those risks are higher, then your personal risk is also higher. And so we've looked into using that as an alternative way to look at equity impacts based on individuals grouped by their social vulnerability index. So, we presented at NADO on integrating different data sources, but that's one way we found that we can supplement the value of the claims database with a little bit more information that's publicly and readily available. So.
Yeah, and I'll just jump in on the public reporting side. We've actually done just that, where we took measures from our community dashboard, which is our population health report, and we pulled data from the census, and we paired the social vulnerability index, the measures from there, and we combined the two to look at any relationships between folks going to the ED, for example, for our sort of unnecessary ED visits what's that relationship to their income? What's that relationship to their access to transportation? How strong are those relationships? And we made a nifty map. It's on our website. It's called the Health Equity Analysis. We love it. And we did something very, very similar for the governor's office. There's the Office of eHealth Innovation that specifically looks at telehealth services versus in-person services, and seeing if folks, those more social determinants of health factors impact whether folks are going in person to get health care or using telehealth. And again, targeting at that sort of census level, that neighborhood level, to help inform resource allocation policy initiatives from the governor's office to look at where they can be supporting people and meeting folks where they are to get the health care they need.
Okay, any other questions, comments, answers to their questions?
I
Anybody
saw
want?
one other hand before Gonzo went.
Yeah, it was on just for a second and it disappeared, so I didn't catch who that was. Michael Adams has a question for you in the chat if you want to field this one. Oh, actually, it looks like your website and other APCDs indicate insured people covered by federal plans such as the VA, TRICARE, and Indian Health Services, which are not available in Colorado APCD. Keep in mind, if a person has commercial Medicare or medical assistance insurance and presents their insurance information to a VA or IHS facility, some of the data can show up in APCD. APCD facility or provider data can be reviewed to see if there are any of your VA or IHS facility names present. Well, that's a lot. Okay.
That's a lot. I am not the data. None of us are actually the data quality people at CIVHC. We are working really, really closely with the VA to actually integrate their data into the Colorado APCD. We have a very large VA facility in Colorado. This point that that Michael, I think, is making is really interesting, and I'm happy to share it. I'm sure there are CIVHC folks on this call as well, but I don't know enough about sort of that piece of it, how we could sort of identify those providers in our data, but really interesting.
Yeah, I think
Yeah,
let's go ahead, Rachel.
Oh, I was just going to say, if this was at all in regards to the American Indian Alaska Native analysis that we did, that was definitely a limitation of the analysis. There is robust data from IHS that our partners had access to. So this was really identifying folks that are not enrolled in IHS and who have maybe commercial or are on Medicaid and identify as American Indian or Alaska Native. So we definitely kept that in mind as well as a limitation on that analysis.
And a note about that, and then also another quick note is with the passing of the Affordable Care Act in 2016, that expanded eligibility for Medicaid for American Indians and Alaska Natives. So many folks have both IHI as well as Medicaid. So some folks are represented in our database. And I'm not sure, Michael, if I'm misreading this, but just to clarify, the claims that we receive are from the payers. So the facilities themselves do not submit to us, it's the payers. So anybody who has Medicare or medical assistance insurance or anything like that, regardless of the facility they visit, that will still get reported into our database. So it's tied to the type of insurance that they have rather than where they're actually accessing the care.
Yeah, I think it's a good point. So, for example, community health centers, fairly qualified community health centers, we might think, oh, we don't have any data on them, but you might, because a lot of clients of those centers have Medicaid or have private insurance. And so if you could identify those facilities or those clinics by some sort of provider number, you might be able to learn something about the care that goes on there. I don't know how much you could learn, but you could do that. And the same could be true of VA or IHS facilities. If people who are going there have some other form of coverage and they're getting billed for those services, it may be able to tell you something.
And you're absolutely right. We've actually been, sorry, Rachel, go ahead.
No, you go ahead.
Okay, yeah, we've been working this past year on finding ways to improve our ability to identify claims that occur at a specific location or facility using a combination of different data points from those claims. And we've also partnered with and had conversations with FQHC billing teams and folks who work a lot with the FQHCs to really understand not only what their populations look like. So we have estimates from the FQHCs in Colorado of the proportion they serve who are uninsured versus insured. That helps give us a sense of how much of your population are we actually capturing when we do find claims at your location. But also we've had some really valuable insights from them as to how those claims might show up because the billing practices are so different in FQHCs versus other clinic types.
Yeah, no, we had done just a quick comment, and I'm going to get to this question from Helen. When I was working for the Utah BCD, the federally qualified health centers desperately wanted to be in the database so that they could do quality comparison to show that they were in fact providing quality care. And so we were able to work with some of them to provide for us things that looked like, we called them pseudo claims. They created a claim as if they were going to submit it to insurance and then just put a dummy insurance company in there and ship those over, and we could load those in. So that is an option. Again, puts the burden on them to do the work. But if they really want to be in the database, they can do that. They have billing systems. That's not the question. They just needed to invent a dummy insurance company, bill all of those self-pay claims, created those in their system as dummy claims, and then we could import them into our system. So it's an option.
That is a fascinating suggestion, Norm. We might have to follow up on that.
Yeah,
Val and I have been working very hard on connecting with a whole bunch of UHCs and school-based.
And I'm happy to kind of consult a little bit more about how that worked from their end. But we do have a question from Helen. What challenges do you face with working with the payer market today? Just curious on your thoughts.
Yeah, one of the, again, we are not the data quality people who are actually the ones that interface. I think the key and the kudos to our data quality team, because they're excellent at this, is building the relationships. There is high turnover, people leave, but our data quality team has built some really, really important relationships with the payers. We also get annual files, which they don't come through the APCD, they come through the payers themselves. Annually, it's a different process, and it requires a lot of hand-holding, a lot of communication. There's really related to prescription drug rebate information and APM information, and just through that experience, I work closely with that team for the reporting piece of it. It is a lot of just relationship building and being able to follow up and have conversations and clarify things and keep the lines of communication open with them. And then I'll say, sort of on an enforcement mechanism, on a compliance mechanism, again, we are not those people, but we have some amazing compliance folks that we work with, really leaning in on our state support system, our state sort of framework of how an APCD should operate, and help and leveraging that relationship when things do get dicey. But luckily, we've really rarely had to do something like that. Our compliance team is really great. But those are sort of kind of the big themes that we lean on to work with the payers.
Fantastic. Do you have another comment here from Ertug? Your AIAN data request, I am curious to see if you've compared your numbers against census data to see if the proportion of AIAN population in claims data is similar to the census data.
Yeah, that's a really great question. We did not do that for this specific project, excuse me, but that is something that we have done for numerous other projects. This was a pretty small scale analysis. CIVHC has a really wonderful equity fund where we support some community partnerships at full cost for evaluation services, and this was through that. So it was a rather smaller analysis. But that said, I would be very curious if we do get this partner back to do some comparison to census level data. That's something we do for a lot of our other analyses.
And adding to that, though we didn't do that kind of, presumably that would be kind of a benchmarking comparison just to get a sense of how realistic is what we're capturing in terms of looking like the population overall. We do work very closely. So when we pull these numbers, we don't just send them to the partner and say, here are your numbers. We do kind of our preliminary pull, we do our analysis, and then we sit down with those partners and have a discussion. And with this particular partner, the first set of numbers that we reported to them, their feedback was that those numbers seemed really low, and they thought that it might be the way that we were categorizing AIAN folks. And so we worked with them to adjust those race and ethnicity categories that we were reporting on. And we were able to find many more individuals than we had originally able to locate. You would think with something like race and ethnicity, it would be a pretty straightforward algorithm. It never is. But we do kind of a temperature check with the subject matter expertise folks that we were working with, just to get a sense of, based on what we're seeing in the CIVHC, does this ring true, or is it reflective of your real world experience in the work that you're doing? And that really helps us both perform better analyses as well as help with interpretation of the data and finalization of the reports.
Yeah, I would just jump in and share if anyone's interested in how that actually worked. I think I may have seen Heather Cruz from Wheel Count on this call, potentially, which would be so exciting if she is on this call. But Val and I are very big fans of kind of looking critically at how we collect our race and ethnicity data. And so what we realized was that we were actually categorizing folks who identified as Hispanic in a separate bin. So folks that identify as both Hispanic and American Indian Alaska Native, which turned out to be a very large percentage of that population, were not being represented in that original count. So we wound up doing several different combinations for this specific partner so that they could see all of the data comprehensively, and we could share as much data as possible with our suppression rules. And so in that way, it would have been interesting to look at the census overlay, but our categorization was different and was guided by the partner we were working with. And so that was really exciting, and also has informed a lot of our race and ethnicity categorization on new projects.
Any other comments or questions?
Okay, go ahead.
What version of QuickBooks did you get?
2024?
American.
No.
Oh, for Windows.
I don't see any hands, so maybe we'll just turn it back over to you all to just kind of wrap up with your concluding thoughts, and maybe challenge everybody to take some action based on what we've talked about today. We're all thinking. All right.
I can go ahead. I think for me, so my background is in public health program management. So I worked for community organizations directing nonprofit programs for 15 years before I moved into this role at Civic. And I was honestly like almost a little worried that I would be moving away from that space and into this more healthcare focused area. And the more I learn about the claims data, there are huge challenges, absolutely. And there are some really cool projects that we can do that can promote and support public health improvement efforts that are happening. And I think being able to creatively think of this data source in new ways and both what we can and can't do with it has really helped me think about like my own priorities in terms of the kind of analyses that bring me joy, and being able to equip organizations that often struggle to access data sources. And so just thinking about what kinds of partnerships you have and that you've built, and how those might be expanded or shifted to be able to have a broader impact is just kind of move beyond the limitations and get a little creative and wild with your brainstorming. That's what I would charge you to do.
Fantastic. Claire, Val, anything you want to add, or we can leave it with Rachel's great challenge?
I think Val got it. So I'm
Okay.
good. Rachel,
Well,
I don't know if you have anything.
Anytime a challenge involves getting a little wild, I think it's a good challenge. So on my screen right here, I have a little sticky note that says, feel free to go a little crazy. So that's the same idea here. All right, well, thank you, everyone. We will see you again for our next Hot Topics meeting at the end of March. We're looking forward to that as well. And again, don't forget to pre-register for our in-person meetings in Austin, Texas in May. We'd love to see you there, and maybe we'll all get a little barbecue together. So, okay, thank you, Valerie, Rachel, Claire. Thank you, everyone, for joining us, and we'll see you all again soon.
Thank you all.